You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is the first in a new series we'll do together. Our usual chats, as you've noticed, mostly go from the general to the specific. Starting with this episode, I'd like to focus on a specific, high-yield topic. As we say in teaching, an educational hit and run. Our first Focus On episode, breath-holding spells. This is analogous to the nursemaid's elbow. You know, when you can make a diagnosis on the spot and use your superpowers to set that radial head back into the annular ligament. With breath-holding spells, if you take a careful history and do a focused exam, you can cast that spell of magical medical reassurance, of course, precautionary advice. Ready? Let's focus. Think of breath-holding spells as a toddler that just can't even. It's a tantrum on steroids, which means you have to be old enough to have a tantrum. It's possible to have breath-holding spells as young as 6 months of age, but really it typically starts around 18 months of age, prime toddler time. In fact, 90% of breath-holding spells start at this enchanted age of learning what no means. From a medical perspective, we can't completely map out the autonomic nervous system pathway here, but from a humanistic standpoint, it's very clear. We know that our physiology is tied to our emotions, and toddlers have big little feelings. They're growing by the day, except their understanding of them is developing more slowly than the episodic rush of emotion, frustration, and exclamation of, "How dare you!" usually pronounced, "Ah!" Where we come in as medical professionals is to make sure that the presenting complaint matches what we would expect in a benign condition, and that we've thought through the dangerous differential. So here's a vignette. Max is an 18-month-old rambunctious boy whose worried mother brings him in for fainting and not breathing earlier today at home. He arrives to the ED looking like a happy-go-lucky child, normal vital signs, normal general exam. Probing further, there have been some changes in Max's home life. He has a new baby sister, so that's a whole thing. And to top it off, Mom took away his favorite singing truck so that she could, and again, how dare she, give him a bath. Max was scandalized and outraged. Doesn't she know he loves his truck? Couldn't she see he was playing with it? Well, that started lots of big little feelings that are hard to express even for grown-ups, and he cried and cried, and that made him more upset, so he ugly cried and cried and cried, so that he cyanotic cried, and finally his autonomic system said, "You know what, Max, you're stressing me out too, and it's time for a quick syncope nap." Max turns a nice shade of blue in the face, falls over, and seemingly he's asleep. To the parents, of course, seemingly much worse than that. He wakes up slightly dazed and a little less rambunctious. The autonomic system wins again. If you press the family, you may find there's a family history of the same, especially in siblings, estimated to be about 25%. They can be scary, and children can have a few myoclonic jerks after this. After all, there is cyanosis, and if you happen to know his SpO2 at the time, strike that, I don't want to know. But there's probably some low-key hypoxia happening. Luckily, very, very transiently without any long-term consequences. Really, it's a benign condition, just a scary one. My point here is that you can accept all of this, cyanosis, breath holding, even myoclonic jerks, as long as the child fits the bill. Epidemiologically, age; contextually, rage. Max had a cyanotic breath holding spell, which is the most common type, and is usually the train wreck you can see coming. It can be the beginning of a long road of repeated attacks, and some children may end up having them almost daily. We'll talk about precautionary advice in a moment. What to do? Not much in the ED. There is some association with iron deficiency anemia, so you can think about that. Probe for some reasons Max may or may not need to get checked out for it, but please don't feel obligated to go chasing things in the ED. Cyanotic breath holding spells are a clinical diagnosis. And now for the slightly scarier version of breath holding spells. Cindy is a 20-month-old girl with no past medical history who was in the kitchen with her mother when she somehow got a hold of a sharp knife and cut her little finger with it. She screamed. There was blood, and before Mom knew it, Cindy had collapsed on the floor. Did I mention there was blood? Mother was beside herself. She called EMS, and here is Cindy with an oversized gauze rolled all the way up her arm, enthusiastically looking around at her new surroundings, sitting up with her blood-stained unicorn doll, a happy little clam. Her vital signs are normal from the medics. You unroll and unroll and unroll her bulky dressing to find... Where's the cut? Oh, here it is. On her small finger, 3 millimeters, hemostatic. It was really hard to find. Cindy is going to make it from a trauma perspective. But wait, was this a breath-holding spell too? Well, yes, it was. A pallid breath-holding spell. This is the train wreck that you don't see coming. The train just jumps off the track. Pallid breath-holding spells are less common than their cyanotic cousins. Usually this is a sudden surge in the autonomic system from an acute, painful stimulus. There can be a few seconds to even a minute delay from injury to syncope. It could be a little confusing if the injury was a blow to the head, but if the mechanism was minor, for example, like running around the house, bonking into a door frame, that mechanism is pretty weak sauce. Not concerning in a healthy child. The reaction, of course, gets our attention. It's only natural that Mom saw blood, a knife, and a passed-out toddler. Anyone would be upset. But when we take our time to get the sequence of events, we can use our pattern recognition. Again, age, context. No other crazy red flags, and we can call it for what it is, a pallid breath-holding spell. The only twist here is, in this less common version, that there's a slightly increased incidence of pre-excitation in these children. So getting an EKG for pallid breath-holding spells is a good idea. In fact, it's recommended. This is not really the case for cyanotic breath-holding spells. The idea is that there may have been some prolonged bradycardia due to pre-existing long QT syndrome, for example. Of course, we always examine the pediatric EKG for all other pre-excitations that can cause even tachycardia. The tough thing about pallid breath-holding spells is that the workup in the ED is usually not very fruitful, and you have to send home a family with, well, it's probably fine and normal, but this may happen again, and it may be his heart. This is when you really want to spend time with the family to explain what's going on and what to expect. There are cases where the child will have ongoing similar spells, and he may eventually be put on various medications that don't really do anything. So it's important to know that you will likely not be the last doctor to see this child for this complaint. Explain your role in the continuum of care, and this itself can help to preserve the parent's trust and willingness to follow up. Okay, to recap. Toddler life, am I right? Breath-holding spells come in two shades. Cyanotic, The train wreck you see coming. Cry, 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 blue, down for the count, maybe a few myoclonic jerks, back up and at 'em shortly. Maybe anemic, probably not. Have to counsel parents about normal interactions with toddlers, and that's a whole other talk. Pediatrician follow-up really is important, if only to help the parents cope with what can be a challenging time in the child's development. Pallid breath-holding spells are the train that was chugging along until it got shoved off the tracks. Immediate, usually painful stimulus, what looks like a drop attack. There may be an association with a congenital dysrhythmia, but usually not. These families need a little more counseling and closer follow-up. An EKG in the ED is usually all you need to screen. Having said all of that, let's make sure that we feel comfortable with the high-yield differential diagnosis of breath-holding spells. Benign myoclonus of infancy happens in the young infant, usually after the neonatal period and before the first year of life. They may have episodes of spasms, myoclonus, shuddering, or even atonia. These happen more and more frequently, often at certain times of the day. They end up all being fine as well. After a normal workup, normal EKG, normal EEG, these children with benign myoclonus of infancy, it's all in the name, they don't have a higher risk of epilepsy. These can be distinguished from breath-holding spells in that these are younger children, the presentation is more bizarre, and there usually isn't an inciting context. Much more myoclonus than mega feelings. Shuddering attacks, yes, that is the medical term for them, they happen in infants, usually with feeding or when the child is upset, so these can be mistaken for breath-holding events. However, shuddering attacks really are that. The child shivers, he may stare, there may be some flexion or stiffening, increased tone, all of that. They go right back to being normal. It's kind of like an active absence episode. The EEG is normal, their development is normal, they eventually grow out of it. Shuddering attacks can be differentiated from breath-holding spells in that really it's an active phenomenon and the child doesn't lose tone. In fact, they stare and have increased tone. Sandifer syndrome is a term for something you see all the time. It's baby GERD on steroids. When an infant has a lot of reflux, that acid and milk is coming up his esophagus and he wants to keep it down, so he arches his back, elongating the path of the reflux as much as possible. What does a parent see? A child who maybe chokes, maybe has short apnea, arches and has increased tone, maybe a few myoclonic jerks. Almost always about 30 minutes after a meal, these children look well in the ED, and they should be just seen as very symptomatic of their gastroesophageal reflux and not an autonomic or nervous system disorder. Now, the differential of an infant or toddler acting weird is much longer than that. These are the high-yield, high-impact players that can help us keep out of trouble in the acute setting. So to recap, breath-holding spells are cyanotic after crying, pallid after pain. Pallid needs an EKG. Both need a careful history and physical. If it very comfortably fits in this presentation, the context seems right, despite everyone's initial anxiety and fear, you can comfortably make this diagnosis, wave your magic wand of reassurance, and break that spell. Well, what do you think of this new focused format? Drop me a line and let me know your thoughts. The idea is to sprinkle these in from time to time to give you high impact, focused treatment of a particular presentation. Thank you for listening. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.